In this short video, we will review some of the important complications of diabetes. First, something to just mention is you're going to want to make sure that you memorize the diagnostic methods for diabetes. And most importantly, for our testing purposes, as we will focus on the hemoglobin A1C, so being greater than 6.5% is diagnostic for diabetes. And this test is a nice test because it gives you kind of an overview of how the patient has been managing their diabetes over the past 3 months. A fasting blood glucose level of greater than 126 will also be used in the diagnostic process, and for this the patient needs to be NPO for at least 8 hours. Just real briefly, when we think about different types of insulin, I'm not necessarily asking that you memorize the different onset, peak, and duration, but you do want to kind of have a general idea that obviously rapid-acting insulin is going to have a very quick onset. So you can see where it's peaking there in 30 minutes to 3 hours, as this is really where the patient is going to or could potentially experience some hypoglycemia if they did not eat. So it's really important when they're on those rapid-acting insulins that they are taking their insulin and then eating very shortly after taking the insulin. Same with short-acting. You can see that the onset is a little bit longer than when we talk about rapid-acting, but it's still going to kick in within 30 minutes to an hour, and you're going to have that peak in about 2 to 5 hours. So again, if they don't eat their breakfast, you're going to see some hypoglycemia kicking in. But you can see with both the rapid and the short-acting that their duration is short, and that's why they need to, again, have insulin with their lunchtime meal, because the insulin that they took is no longer working and they'll need to take some more insulin. When we have people taking more of the intermediate acting insulins like NPH, you can see that the onset is longer and the peak is much later. So this person is going to be at most risk for having some hypoglycemia around lunchtime. And so it's real important, again, that even though they may not need to take additional insulin at lunchtime because it's going to have longer coverage, that this is where they're going to have the highest incidence of hypoglycemia if they do not eat lunch. So it's really important with patients on NPH that they're really scheduling their meal times more strict than sometimes the other ones, because you could see with the rapid and the short acting, they're going to need to take insulin again, where this one, they're probably not going to be taking insulin again till around dinner time. And so then you would again see that they would have that potential to have hypoglycemia again while they're sleeping. So another reason why it's very important for them to be having a snack before they go to bed. The long-acting insulins like Glargine, Lantus, those don't have a peak. They have a 24-hour duration, so patients usually take these once a day. I am seeing patients taking it twice a day. Increasingly, you'll see that happening with patients too, and that's going to help give them more of a steady all-day coverage. I'm thinking just a little bit more about, like I said, we were going to focus on complications, but I wanted to kind of get a little bit of an intro in there. Some of the complications for these patients with diabetes is going to be hyperglycemia and hypoglycemia. And when we think about hyperglycemia, a lot of times we think of the 3 Ps: polyuria, polydipsia, polyphagia. So we have patients with hyperglycemia, and if we don't do something to treat the hyperglycemia, such as give them their medications, maybe they need increased medications, they can progress into DKA if they are type 1 diabetic. They can progress into HHS, hyperosmolar hyperglycemia syndrome, if they are type 2 diabetics. So for these patients, we'd want to make sure their meds are being taken, maybe even adjusted, and during times of hyperglycemia, we want to increase their fluid intake, and they should be checking their blood glucose more frequently. Hypoglycemia, it'll vary on what numbers different textbooks or different facilities will use for hypoglycemia, but usually anywhere under 70, we're worried about hypoglycemia. Some patients will feel hypoglycemic if their blood glucose approaches 80, 90, and some patients can be in the 40s and not have any signs and symptoms that they feel themselves. For you, though, you have the signs and symptoms that are listed here that you would be watching for someone who is hypoglycemic. And if you have a patient who's experiencing any of these symptoms, your priority intervention would first be to check a blood glucose, because you'd want to see what is their glucose at this time. A lot of times, signs and symptoms of stroke can mimic signs and symptoms of hypoglycemia. So if we have someone who's having these signs and symptoms, we can check a blood glucose right away. If we know that it's low, we can then go on and treat the hypoglycemia. And if, let's say, we said these signs and symptoms and they're not hypoglycemic, then that would take us down a different pathway to maybe be alerting our stroke team and going doing those types of assessments. But if we find that it is hypoglycemia, this can be caused by too much alcohol, not enough food, too much exercise, maybe too much insulin and not eating, weight loss. If we have experienced this, then we are going to want to give these patients some glucose. So if they're alert and oriented, we can give them 15 to 20 grams of simple carbohydrates, followed by then bread, peanut butter, crackers, something like that. So if we can get them some juice, some soda, something to bring their glucose up, followed by some type of food or meal, bread, something like that. If they happen to be lethargic, comatose, unable to swallow, and they're in the community setting, a lot of times these patients will have glucagon, so they can take 1 milligram of glucagon sub-Q. And a lot of times in the hospital, we're going to be giving dextrose IV push. So 20 to 50 milliliters of IV dextrose will be the treatment. And then for all of these, whatever treatment we used, we would continue to check them every 15 minutes and do additional interventions as needed until we get their blood glucose to an acceptable level. If you are in a hospital and the patient appears to be crashing, this would be an appropriate time for you to call your rapid response team. So when we think about diabetes and some of the other complications, we do have DKA and HHS. And so these are some more of the more life-threatening complications. And when we think about DKA, something to remember is that this is always going to be our type 1 diabetic, okay? And when we're thinking diagnostic-wise, to be diagnosed with DKA, you're going to have a blood glucose that's greater than 250. Their pH is going to be less than 7.3. Their bicarb is going to be less than 15. And you're going to find moderate to large amount of ketones in their urine. So that's going to be, when you're looking at diagnostic-wise, that's going to be different for DKA and HHS. So again, this will be for our type 1 diabetics. This is considered a medical emergency. When this person comes in, they are usually very dehydrated. They can be very lethargic. They are very ill. So although we might think that giving insulin is our number one priority, actually our priority is to restore fluid volume, because dehydration is what can kill the patient. So typically they're going to be getting IV fluids at a fast rate, a large volume. And you're going to do this to restore the urine output, raise their blood pressure. And then we're also, before we start our insulin drip, we have to look at their electrolytes. So because someone with DKA is going to have profound diuresis, and a lot of times they are drinking lots of fluid, their potassium levels are typically very low. So we have to replace that potassium. This is very important. We have to do that before we start the insulin, because we have to remember that insulin, IV insulin, will also cause hypokalemia. So when we begin that insulin infusion, it's also going to decrease the potassium. So we want to make sure the potassium level is, we don't have to get it up to the normal level before we start the insulin drip, but we have to begin replacement. In addition to having replacement, the other thing is this person definitely, if they have any type of potassium imbalance, should be on telemetry, because remember, we run the risk for lethal dysrhythmias anytime we have hypokalemia or hyperkalemia. So we'd have this person on a telemetry monitor. We would be replacing their potassium, and then we would begin our insulin infusion. In some cases, you might see sodium bicarbonate started as well. That is a buffer to help decrease the renal tubular acidosis that's occurring. But more and more, you're not seeing sodium bicarb being used, partially because there's been some studies that are showing that it's not necessarily that effective, but there's also, for whatever reason, it often seems to be on a nationwide shortage. So just to kind of recap real quick before we move to HHS, what we said for DKA is that you were type 1. Diagnostic-wise, your blood glucose was greater than 250. Your pH was less than 7.3. Your bicarb was less than 15. And this person had moderate to large amount of ketones in their urine. Before we talk about HHS, this is going to be for those type 2 diabetics. And type 2 diabetics typically don't go into DKA because they have some amount of circulating insulin that prevents them from going into DKA. But this time you might see this person's blood glucose much higher, so greater than 600. You might see increased serum osmolality. And a lot of times they don't have ketones in their urine, and if they do, it's usually a very small amount, so either none or very small. So let me just erase this here. Perfect. So when we talk about the treatment for HHS, it's very similar to DKA. The one thing that we have to remember here is now we're talking about type 2 diabetics, which may be an older population, and this type 2 diabetic might have multiple comorbidities, such as heart failure, renal failure, those types of things. So our main priority, again, is still to replace the fluid volume so we can restore urine output and increase their blood pressure, but we'll be running it at a slower rate. We'll be watching to make sure we're not putting them into fluid overload, and we will continue to always worry about potassium level first. So our K is going to be very important. And we would do the same parameters as we did with DKA. So we would get them on telemetry. We would replace the potassium as needed. And then we would begin our insulin infusion, if they did an insulin infusion. So it may vary. This person, if it's not very high, they may decide to just restore the fluid volume and increase their insulin doses and maybe their oral medication, or they may be put temporarily on an insulin drip. So it will depend, again, on the patient. You could see treatment either way, but the big thing we want to do is make sure we're restoring the fluid volume and worrying about their potassium levels. For both patients, whether they have type 1 or type 2 diabetes, they are at very high risk for chronic complications. And the complications occur from having an elevated blood glucose level. So when you have these high levels of glucose circulating in your system, they damage your nerve endings, they damage your arteries. It really can cause all kinds of problems throughout the entire system. So someone with diabetes, and the more it's uncontrolled, the higher your risk factors. Increased risk for stroke, hypertension, lots of different skin problems, atherosclerosis and coronary artery disease because you have an increased rate of atherosclerosis, neuropathy, so anything with nerves, so you're going to have problems with neuropathic pain. You're going to have problems with nephropathy, so the kidneys, causes damage to the nerve endings in the kidneys, also causes renal tubular acidosis, which can cause renal failure. It can affect the retinal arteries. So there again, you have problems with vision. And so you can really see this patient can have problems from head to toe, really. Also, the diabetic patient can be immune compromised. They can run risk for infection. If they get an infection, they typically take longer to heal. So whether that's a respiratory infection or a foot infection, you can see the problems with, if they get a cut on their foot and it doesn't heal, not only do they usually have peripheral vascular disease, so they're having decreased perfusion to the lower extremity, they have decreased healing, they have decreased sensation, so they don't necessarily always know that they have some type of injury on the foot until it becomes really infected. So just quickly to kind of review some of the important things when we're thinking about teaching for this patient, they're going to have to know about self-monitoring, and that's going to be both of them, type 1, type 2. They're going to have to know about self-monitoring. They're going to have to know about medication administration. So whether it's that they're taking oral medications or they are taking insulin, they're going to need to learn how to do that. So if you think about insulin administration, person's going to have to know how to check their blood sugar, draw up the insulin, possibly mix insulins if they're doing that, and give the insulin in the proper location. So there's lots of teaching. There'll be diet teaching, And that can vary, again, based on the endocrinologist's recommendations. It might be that they're counting carbs. It might be a more calorie-based diet. And again, that will vary between type 1 and type 2 diabetics. Both should avoid alcohol. You want to make sure that they also try to avoid stress. Stress can increase your blood glucose, also decrease wound healing. They should be avoiding sick people, so they try not to get sick. They should have good hygiene. So hygiene is important. Again, it's for not only is it important for you to have good hygiene just to maintain health, but we're thinking, about our foot care. So looking at the feet is very important. Diabetics should do foot care every day. They should be washing their feet, inspecting their feet. They should be going to a podiatrist for their nail care. They should wear shoes, and they can be soft-soled shoes, but we're really worried about any injury, any cuts, anything to the foot is very important to avoid. Exercise will be important as well, and it's recommended 150 minutes of aerobic exercise each week with 2 days of strength training. Now, again, that might have to be modified based on your patient's age and other comorbidities, but exercise is going to be very important for this patient. So you can see, depending on the patient and their needs, there could be a lot of teaching, especially if they're a new diabetic. Some of it might be more reinforcing or adding additional information when you're doing the teaching, but a diabetic, especially a new diabetic, is going to need lots and lots of teaching. So hopefully this is helpful. If you have any questions, you can always email me. Thank you.